name is Jody Gutkin. I am your presenter for Cardiovascular Disease Rehabilitation Considerations. I have been a physical therapist for over 30 years, and I've also been involved in physical therapy education for over 20. And I look forward to discussing this topic with you today. The focus of our course today is to examine the current literature on several specific cardiovascular diagnoses. We'll specifically examine hypertension, atherosclerosis, atrial fibrillation, and heart failure. For each of those, we're going to remind ourselves about the risk factors, currently what is understood regarding the pathogenesis, and also the therapeutic considerations for patients that we are treating with these diagnoses. The rationale for the course is not only to look at that contemporary information, but also to expand our viewpoint a little bit more in terms of the populations where we can address cardiovascular concerns. Looking at, as we go through this information, don't just think of those patients that are coming to you for cardiac rehab with one of these primary diagnoses. Also consider your patient populations of various ages who have cardiac diagnoses as comorbidities. When we're developing our exercise programs, maybe we can address overall cardiovascular health along with whatever we're primarily treating them for. And then, in general, for all of our patients, being forward thinking in our discharge planning and the types of programs that we develop and additional referrals that we make so that we can really incorporate cardiovascular health and wellness looking towards their futures. We are going to examine several different studies. All of the resources that I utilize to compile this course are included at the end of your course notes packet as references. Some of them are additionally indicated on specific slides. And then any links to resources that I thought would be helpful in your clinical practice are included at the end of that course notes packet also. To accomplish all of this, our goals and objectives are aligned. We are going to expand on your already existing knowledge base of risk factors and pathogenesis to include some of the newer theories and classifications of these different conditions. And then for each condition, we will look at specific considerations that you should incorporate into your clinical decision making to develop the best programs for these populations or individuals with these diagnoses. Disclaimer, as with any course that you attend, when you return to the clinic to apply this information, you're going to do so in accordance with the federal, state, and professional regulations where you're practicing, and no conflict of interest exists for the presenter or the provider of this course. As you work through the presentation, you will notice that several of the slides on the bottom right have this blue icon that says consider this. That's to let you know that those particular slides are going to be helpful when you go to complete that course post-test later on today. We're going to start with a brief discussion on general cardiovascular health and wellness as a foundation for our topic. And we know that cardiovascular health relates to the health of the heart and blood vessels. We're looking at preserving it if it is optimal level. And then if it is not an optimal level for an individual, we're looking at enhancing it. And the American Heart Association has developed the campaign of Life Simple 7. This is a way of promoting to the public those basic core behaviors and factors that play a positive role in encouraging that healthy lifestyle for both youths and adults of all different ages. It targets the different lifestyle and risk factors for cardiovascular disease. We know that individuals need to stop smoking, increase their physical activity, where we play a role, manage their weight, where therapy is also involved. And then diet, we do play a role in by outside referrals, ensuring our patients have the physical mobility to prepare food, the physical ability in order to ingest that food. And then also looking at managing cholesterol, blood pressure, and glucose control, which really relate back to these other factors that we have an opportunity to have a positive influence on. There are many resources available through the American Heart Association if you're looking for opportunities for post discharge programs for your patients of all ages, developing more community outreach or education programs. I included links to these different resources. This is always a good place to start and then expand from there based on what we're going to discuss on positive impacts. In order to look at the different needs that are required nationally to promote health and wellness, there's the Behavioral Risk Factor Surveillance System, the BRFSS. And this data helps frame the different concerns that we already know exist. This surveillance system is through the CDC, and what they do is they actually go old school making phone calls because not everyone has the same access to technology across the country and they want a broad base of surveillance data. And they're asking questions related to the major causes of premature mortality and morbidity for the general population. It looks at things related to the topic that we're discussing today: tobacco, exercise, fruit and vegetable consumption, cardiovascular health, oral health, anxiety. And as they gain this data, there's a portal that's available, and I get lost in there every time I go in. We're going to look at some of the data that's relevant to our topic for today that you can pull so much to see what the needs are in your specific areas to service your community best. The way that this is utilized nationally is to really inform public health policy. And some examples of how different states have utilized this: when we look at the shift to banning smoking inside restaurants, this data was utilized. A little more recently in Nevada, they noticed a trend in the data results towards binge and chronic drinking. So the legislator was able to utilize that data to pass a bill placing a specific tax on wholesale alcohol to try and curb some of that. So individual states can use this data in different ways, and it's something that we can access also. If we look at dietary aspects for the general population, dietary approaches to stop hypertension. This is a specific diet plan that includes high fruits, vegetables, whole grain. It's more plant friendly by limiting fat, dairy, meats, and oils, also limiting all those sugary beverages. And that's nothing new. We're already well aware of that. Well, according to the most recent survey data, if we look at the states on this map of the data from the survey, the states that are specifically identified in dark blue and teal, these are the states where, when we look at the population in those specific states, only 20 to 44% of the people that live in those states consume vegetables more than once a day. Now, how do we use that data in rehab? Um, I look at this data in some different ways. It makes me consider with patients: do they physically have access to the food that they need? Is there a food insecurity concern? Do they need referrals out to different community resources? Do they physically have the ability to go shopping or prepare the food, or a caregiver that can? Do they have the physical ability to eat, swallow, have the appropriate posture? Are they in too much pain to even feel like eating? There's ways we can expand this data to target our different populations and gives us different opportunities to expand the ways that we can have a positive impact on cardiovascular health for our patients. Looking specifically at this DASH diet, the way I have it here is an infographic. In your course notes, I have it written out a little more specifically. It's a balanced eating plan. The focus on this that's different is the goal of including more of the micronutrients, potassium, calcium, magnesium, through whole foods as opposed to supplements. One study looked at, well, how can this diet be more widely promoted to have more utilization of it across different socioeconomic classes, across different ages? And the survey the research study proposed that if they increase the SNAP funding, that's the lower income funding for food, by 30% supplement for fruits, veggies, whole grains, and then across the general market have a 10% decrease in the cost of fruits and vegetables, the research projected that 230,000 deaths from cardiovascular disease could be prevented by the year 2030. That is pretty significant. Also, looking at that data, they felt that by increasing the funding in that program, which makes us think, well, maybe some of our populations, depending on who we work with, do need those referrals to outside community resources. They felt that they could decrease the socioeconomic disparity of cardiovascular disease by 6%, which is significant. Another aspect of that research study looked at if they increase the tax on sugary beverages, which I was particularly interested in. We do for others, not ourselves. And they projected that increasing a tax on sugary beverages would not have any impact on consumption levels. That if you want that that soda, you're getting it. So different education needed there. Some other aspects, if this dietary programs are something that interests you, the DASH trial, specifically the impact that they recognize it has, it promotes lower blood pressure, lower LDL levels, which are our bad cholesterol, compared to that typical American diet. And then there are some different variations here, and I list the reference for it, comparing the DASH diet and variations of it, controlling sodium, controlling carbs, to see the different impacts for different populations with other comorbidities. Cigarette smoking, we all know that this is something that promotes atherogenesis. There's inflammatory signaling that occurs. It increases adhesion inside the vessel wall of platelets as well as macrophages. That is increasing that plaque formation, decreasing the lumen size where the blood has an opportunity to flow. When they examine every 5 deaths that are related to smoking, at least one is related to cardiovascular disease. The positive here is that this is reversible. And if we look at the states where there is the higher incidence of smoking, individuals in the dark blue and teal states, again, if we look at the dark blue and teal states, we're looking at similar parts of the country that individuals in those areas, somewhere between 16 and 24% of the individuals in those areas are smokers. So opportunity here for smoking cessation programs and education. Another aspect is oral health, and that is not a relationship that much of the public is aware of. And it's a huge opportunity for us, even if we're looking at partnering and again, education. And just in our evaluations of all of our patients, there are so many reasons to look up at the head, neck, and face, particularly the teeth. Related to our topic today, we know that someone who does not have good oral health, so as we're looking at that individual, if we notice that a lot of that root or stem of the tooth is visible where that gum is receded, if they have a lot of cavities, missing teeth, what happens is that poor gum and tooth hygiene creates a mechanism where bacteria can enter the system, and then that bacteria is going to flow and it can adhere inside the vasculature, creating actual blockage. It will trigger inflammation and those clot formations. And then it can also travel to the heart, leading to bacterial endocarditis. When we look at different areas of the country, this time we're looking at those states that are indicated in white, we're seeing an unfortunate trend that it's really those same areas of the country where we're seeing about only 54 to 64% of the population in these white states went to the dentist one time within the past year. Now, that includes not just general hygiene, that includes emergency visits where it may not even be part of their general routine. So the data may actually be less than that. Health in this aspect is really important. And again, do our patients have enough standing tolerance, enough balance to be able to stand at the sink and brush their teeth for whatever diagnosis we're treating them for? Or is that something that's falling by the wayside while maybe we're rehabbing them for something else? And then, in addition, our cardiovascular patients in particular, do they have the manual dexterity? Do we need to look at modifying how they do this, some type of bedside setup or some, just bringing it up the point that it is still important. You're supposed to be brushing your teeth for 2 minutes. 2 minutes of standing tolerance with minimal support for many of our patients for a lot of different diagnoses. That's a challenge. So maybe we can connect this goal of balance and standing tolerance to thinking about oral health. Different ways to think about this information. Also, be mindful, just like our patients with total joint replacements, if they're going in for oral care, that we have to make sure they followed up with their physician to see if they need antibiotics. The same is true for our cardiac patients who have prosthetic valves or different valvular damage. They may need prophylactic antibiotics before they go to that dentist. Now we'll move into blood pressure management and monitoring. This is that basic skill that I know we all know how to do, right? This was the easiest practical in school. At least most students thought when I was teaching. I might have some alumni in there that are shaking their head going, ah, that practical made me redo it. When we look at blood pressure management, we need to assess those values. And it's critical to establishing that baseline as well as ongoing assessment of our patients. The question is it being done frequently enough? We know things get very busy in the clinic. In 2019, there was a national survey that was completed of 1,800 physical therapists across the country. And those clinicians indicated that at least half their caseload already had a cardiac diagnosis or they were at moderate to high risk for cardiovascular disease. Only 15% of those clinicians reported that they measured blood pressure and heart rate on the initial evaluation. Not shaming anybody, we all know it gets busy. But I respected their honesty because it brought to light the fact that, especially with more direct access, this is our opportunity as we talk about some of the different presentations of cardiovascular disease to identify it earlier and make the appropriate referrals, because rehab is becoming more of a direct point of entry for many patients. Now, that 15% was actually an improvement. When the same study was completed in 2002, only 4 to 6% of clinicians were assessing vital signs on that initial evaluation. The most commonly identified reason for not assessing it was time and lack of perceived value of that information. We all know how valuable it is at this point in time for that early detection. Because of this data, the Physical Therapy Journal put out a call to action to assess blood pressure routinely, particularly in the outpatient setting. I think in home care, it's naturally done a little bit more, but particularly in outpatient because of that push towards direct access. And when we look at measuring blood pressure, we have our manual type of cuff, and then we have our automatic type of devices. Those automatic cuffs are going to, we know, inflate on their own. And I'll tell you, I've been doing this for more than a minute, and everything used to be manual. Um, so when these automatic devices came out, trust was a little lacking. um, However, if you stick with the research and you use these different devices, they really are found to be beneficial. And as we talk at some of the specific criteria, they may even be a little better than a manual measurement. The Veterans Administration and the Department of Defense Clinical Practice Guideline for Hypertension actually recommends using an automatic cuff, either unattended, where a patient is doing it at their home, or attended when they're with the clinician, and then use an average of the two measurements. Looking at the accuracy of the different equipment, it may seem basic for me to even talk about it. However, I found some interesting things in the literature that is always a good opportunity to pause and say, okay, yes, head nod, I'm taking care of all that. Or sometimes it's a nice reminder, like, yes, I maybe that is an opportunity to change the procedures in my clinic a little bit. In terms of the automatic devices, the oscillometric devices, which one do you get? You may be involved in purchasing. Patients may ask you for recommendations. I am not promoting any particular product. However, there are resources you can go to help make those decisions. The American Medical Association, in conjunction with the University of Chicago, they have a very rigorous process of evaluating the oscillometric devices to see which ones really appropriately measure blood pressure and accurately. They compare it through individuals with many different blood pressure values, comparing those values to measurement through your historically accurate mercury measurement, which we're not using in the clinic anymore. And then they actually have an approved list of validated devices. And those links are available and might serve as a good point of reference. Going back to our typical blood pressure cuff, don't throw these out. Just remember they do need to be calibrated. One study collected blood pressure cuffs from 6 different physical therapy programs, 30 cuffs from each program, and they assessed them for calibration. Unfortunately, what they found is that about 23% of the devices were not appropriately calibrated. We could say, oh, it's just practice in the clinic. It's a reminder, though, that in education, we need to make sure we do that. So I found another study that looked at home health care, where they pulled the devices from different home care practices that clinicians were using. And unfortunately, found that 12% of the devices, when the gauge was resting at zero, it wasn't actually at zero. They weren't calibrated appropriately. So, just a nice reminder for us to add that to our never ending to do list. As we look at the accuracy of manual measurements, there's something called oscillatory gap that occurs when you're listening for the blood pressure. It's either at the top end where there's a little gap and then we may be missing that highest value. And then sometimes it happens at the end also. The way to avoid this is to utilize the technique of radial ablation. And the radial ablation technique, you're going to apply the cuff to the individual. So they have it applied up here. And then you're palpating down at that radial pulse. inflating the cuff until you no longer palpate that radial pulse. That means there's occlusion of the vessel. So that gives you an idea. Note that pressure, and that's about how much is needed to occlude that radial pulse. So when you actually go to inflate that cuff for blood pressure measurement, you want to go 30 millimeters of mercury higher than that to make sure you don't actually miss that high end of the systolic value. Now, the research says that the automatic cuffs, that they are not as sensitive to that, that they're better at accounting for the oscillatory gap. They tend to inflate a little bit higher to begin with, and it's not relying on someone listening to hear it. In terms of the deflation of the cuff, the rate of deflation of the cuff should be about 2 millimeters of mercury per second. And we're listening until it completely disappears. I am, of course, that person when I go to the doctor, they think I have white coat syndrome. I don't. I just am, as we talk about other standard techniques. My blood pressure is going up because I hear how quickly sometimes they deflate that cuff. And I'm like, that's not 2 millimeters of mercury a second. How do you know my pressure's right? So, among other things. So, not to be judgmental, but you know, um, I'm sure some of you can relate. In terms of looking at the research, that traditional of looking at a patient's historical value or asking them and then just going 30 to 40 millimeters of mercury higher than that as our top end of inflation, the research says that really doesn't work, that this radial ablation technique is really the better way. Looking at some of the basics, which are so important. There's a lot of research on this, that utilizing a standard technique, positioning a patient appropriately, it has an impact on blood pressure values. And if we are using these to make our clinical decisions, it is important that we attend to them. Just looking at allowing the individual to empty their bladder before we take the blood pressure, a full bladder is going to increase intra-abdominal pressure, and it has been found in the research to increase blood pressure by 10 to 15 millimeters of mercury. That's significant. If your patient was just rushing to get into their appointment, or that walk or ride through the wheelchair, whatever it took to get them into the clinic or from their patient room down to the clinic, that may have strained them to the point of it being like exercise based on their level. A 5-minute rest may be needed. Otherwise, you may have an artificial inflation of their resting blood pressure because it may not be really a rest for them, depending on how quickly it happened. Individuals should be in supported sitting. Back should be resting. Feet should be flat. Legs should be uncrossed. Particularly with the legs crossing, we know that that is going to increase total peripheral resistance because of that isometric contraction. The heart's going to have to pump faster. Shouldn't be talking either because that causes exertion. Just in terms of where that arm is resting, it should be supported approximately at the level of the fourth intercostal space. Where that sits for the individual is important because of that fourth intercostal space. If the arm is higher than that, we have less hydrostatic pressure, so the blood pressure is going to be lower. And if the arm's much lower than that, we're going to have increased peripheral resistance, and the blood pressure may actually be a little higher. One study said that for every inch higher or lower than that ideal fourth intercostal space, that it can change the blood pressure value by 2 millimeters of mercury. So if you look at all of these things combined, it can have a significant impact on blood pressure. And these are all the things that we need to educate the patient on if they're assessing their blood pressure on their own at home. Oh, and also they said that putting the cuff over the clothing can increase the value of the blood pressure reading by 10 to 40 millimeters of mercury. In terms of out of office blood pressure monitoring, the patient may be using a home unit. And then in terms of ambulatory blood pressure monitoring, this is when the individual is going to be wearing the device. It is going to read their blood pressure about every 10 to 15 minutes in order to get the values over a 24-hour period to see how they're interacting and pressure is changing as they go through their daily life. What's also important with this reading is that it looks at their values during sleep. And if you do have an opportunity to look at that data, restful sleep should cause the blood pressure to decrease by about 10 to 20% in the systolic value. They're developing some different ways to monitor blood pressure. Different types of wrist monitors may be beneficial. So, the wrist type of blood pressure monitoring that's placed on, if it's placed appropriately over the radial artery, might be a good option for an individual where you don't have a cuff the right size for them, maybe someone who is obese. The research says that it tends to overestimate the systolic a little bit, so just be mindful of that. They're looking at different cuffless devices, using a smartwatch, which is going to read the vibrations of the heartbeat. They're looking at devices on the far right here where you put your finger over a value, over the monitor on the screen, and that's going to read the capillary movement. And then they're looking at postage size device, kind of little squares that can be placed over the carotid or the radial artery. The National Institute of Health is trying to come up with something small and simple to give more readings. We're not there yet with that last one. What we're going to look at next are the different types of cardiovascular disease and specific considerations when working with patients with these diagnoses, specifically hypertension, atherosclerosis, atrial fibrillation, and heart failure. Examining first hypertension. Depending on when you went to school, you may have learned a different version of the mosaic theory of hypertension. This was initially presented in the 1940s by Dr. Page, and it's been modified as new information has been learned. The concern with hypertension is end organ damage, that there's ischemia and lack of blood flow to those other organs that causes other pathology. The mosaic theory proposes that all of these different aspects are going to overlap with each other. So it actually becomes kind of more like a spider web of overlapping interactions. And some of the newer ones, just to highlight, we know that there's the focus on genetics. Sodium homeostasis, we know, is important, that the kidneys are going to control the amount of sodium, which controls the water and plasma volume for individuals. But they're also looking at newer theories looking at the microbiome, that there are thoughts that somehow the gut intestinal permeability changes in individuals because of diet, because of environmental factors, and it allows the different immune cells to get into the blood circulation, and then they can impact the blood pressure control mechanisms. And they've done animal studies where they transplant some fecal matter from a mouse with hypertension to a mouse without hypertension, and it did develop increased blood pressure. They're also looking at this pro inflammatory state and how inflammation is playing a role from maybe it is the sodium, maybe it's the microbiota that is going to lead to increased inflammation and increased hypertension for the individuals. In terms of the actual classification and the different blood pressure values that are associated as our definition of hypertension, there are two classification systems. The American College of Cardiology and the American Heart Association are aligned on the left hand side, and then the International Society of Hypertension has their values on the right hand side. What we see is a trend is that it's an and or statement now, that either elevated systolic or diastolic or both can lead to that diagnosis of hypertension. Both of those values are important. Another change that we see is on the American College and the American Heart Association that the terminology of utilizing prehypertension has changed to now being elevated blood pressure. And that's those individuals 120 to 129 systolic, and then still less than 80 of diastolic. Once we get into individuals at higher levels, we're getting into those or statements for that diagnosis of actual hypertension. And these individuals with stage 1 or grade 1, we're looking more at lifestyle management. And then beyond that, we're looking at individuals where they're going to need more pharmacologic management. If we look at the different types of hypertension, essential hypertension is going to be age related. This is usually a primary disease process that results from the different factors that we just discussed: more rigidity of the blood vessels, changes in peripheral resistance, as well as some of those other factors. And then we have secondary hypertension, where the individual may have kidney disease, thyroid disease, some type of even obstructive sleep apnea. Pain medication use can lead to this sustained hypertension where the individual has that elevated level. And this is going to be elevated whether they're with the physician or in the clinic with us being evaluated, and it will be concurrent and matching their outside of the clinic values. Another type of hypertension on the left is our white coat hypertension. This is widely recognized now. These are those individuals that when they go to the doctor's office, and we may see this in rehab, it's really when they're going to get their blood pressure values measured in that healthcare setting, where it's going to be elevated, except when they're outside the clinic, it's fine. Their blood pressure values are normal. The data says that approximately 10 to 30% of individuals diagnosed with hypertension actually only have white coat hypertension. That's where outside of the clinic monitoring and ambulatory monitoring would be beneficial. The concern is that individuals that do present with this, it doesn't mean they're at zero risk. No treatment is needed. Often they just need to be monitored, but it may indicate a predisposition to hypertension in the future. Masked hypertension, in contrast, those are our individuals that they test out fine in the doctor's office, in the clinic, they seem fine. However, they do have instances when they're outside of the clinic with different life stressors where they're going to have that elevated blood pressure. And this is important for us to recognize, because we'll talk about how can we kind of trigger this with low level exercise to see if that individual has masked hypertension. The concern is that those individuals that are maybe not being identified and managed are at a significant risk, and potentially the same risk of end organ damage as individuals who have the sustained hypertension. And that hypertension mediated organ damage is the concern, that as the blood pressure is high and there's that excessive velocity of blood going through the lumen of the vessel, there is some damage that can occur, and this can lead to cerebrovascular accident, vascular dementia, hypoxia of the tissues, as well as all of these different diseases that are indicated. And the important thing here is to recognize that it can affect many body systems. I want to highlight that in our evaluations, when we're assessing our patients with hypertension, we should consider taking a moment to do a simple eye exam, or to see if they do have routine eye examinations, because retinal hemorrhage and micro aneurysms can occur. And if that individual is presenting with balance deficits, they're a fall risk, that would be part of being comprehensive in our management. So they might need some outside referrals. Target organ damage symptoms that individuals present with, we need to differentially diagnose between, is it a hypertension related sign or symptom that we're seeing, or is it of another pathology or condition that's a comorbidity we're treating them for, or not? So maybe we're treating them for something else, and maybe this is related to their hypertension, or vice versa. So, to highlight some of these to consider in your assessment of your patients and then monitoring of them also, an individual that's having chest pain, we need to distinguish, is that angina that is related to their exertion, digestion, those typical triggers? Is it that myocardial ischemia? Or could it be costovertebral joint rheumatoid arthritis? Maybe it is an osteoporotic rib fracture that they've sustained. Is it fibromyalgia, pleurisy? If they also have a lung condition, maybe it is their reflux. We need to be specific in assessing this. As we consider back pain, particularly when patients are coming in as direct access, is it their stenosis where all of the other evaluation components fit with it being related to the stenosis? Or possibly, if they have severe hypertension that's unmanaged, could this be an aortic dissection that's occurring? Same thing with dyspnea. Is it an exacerbation of their pulmonary edema or heart failure complication? Is it just that they are overexerted and they just have generalized deconditioning? What's going on there? When we look at the neurological changes, we're going to correlate that with whatever um, neurodegenerative or other type of neurologic condition or orthopedic condition that's leading to nerve compression, or vestibular involvement. When we look at visual changes, headache, numbness, weakness, these could be indicators of end organ damage from unmanaged hypertension. Same thing when we look at claudication for those individuals. When we look at monitoring blood pressure for our patients as we are performing different activities with them, there are those instances, even we may be receiving them at rest, where we check their blood pressure and it is over 180 over 120. That is extremely high and it is a cause for concern. The questions we need to ask ourselves when this occurs is, what else is being experienced by the individual? What we're looking at here is the American Heart Association recommendations. If someone is recognized to have that blood pressure value, the next assessment that should immediately happen is, are they demonstrating any of those signs of target organ damage? Are they demonstrating do they have chest pain, shortness of breath? Are there any neurologic signs where they're having difficulty with their speech that may lead us to believe they're having a stroke or a TIA? If they are not having any of those target end organ system symptoms, we're going to wait 5 minutes, recheck. If it's come down, then we need to refer that individual back to their physician. Maybe they just need a medication adjustment, and this is called a hypertensive urgency situation. On the contrary, if our individual has that blood pressure and we assess them, they are demonstrating those symptoms of target organ damage. This is a medical emergency where we do need to call 911. This is a hypertensive emergency because this can ultimately lead to life threatening consequences for the individual. Another form of hypertension is referred to as isolated systolic hypertension. This, per the American College of Cardiology and the American Heart Association guidelines, these are individuals who have a systolic blood pressure that is consistently above 130 millimeters of mercury. This blood pressure is recognized as a form of essential hypertension. It tends to happen in elderly individuals as we go through our aging process. The endothelial layer of the blood vessels has more calcium deposits in it that causes it to be more rigid and less compliant as the blood is going through it. The lumen then becomes thickened. So that thickness of the lumen, the opening, and then the vessel ring or layer of the intima and that muscular layer, that ratio becomes compromised where it's really thicker than it is open. As a result of that, fibrotic remodeling is going to occur. There's thickening of the intima and the media, and that leads to less perfusion through that vessel and ultimately that targeted organ damage. There's more velocity going through those blood vessels. There are several different trials that are going on now to look at hypertension in the very elderly, to look at the effects of diet and exercises, lifestyle modification on decreasing age related and all cause mortality, as well as cardiovascular mortality and stroke events. There are many different trials that are occurring related to hypertension, cardiovascular disease. I do include a link in the resources at the end of the course notes packet to see maybe you have some patients that are candidates and you yourself would like to, be on the kind of research end of things by having individuals participate. So those links are available. Seasonal hypertension, I haven't mentioned, I am down here in Naples in Southwest Florida. Seasonal hypertension is something that our Southern clinicians definitely need to consider. Not that our Northern clinicians don't. If you haven't heard of this, it is definitely a more recently recognized phenomena. In its simplest definition, seasonal hypertension is the fact that when the weather changes outside, individuals' blood pressure changes. That blood pressure is actually inversely proportional to the weather temperature outside. Sometimes it's referred to as like a winter hypertension. This means that, for example, we have our patients who are up north where it's cold, where some of you might be right now. So, blood pressure is going to change. Your blood pressure tends to actually get higher when it's colder. So in the winter, your blood pressure is going to increase. The reason this happens, they attribute it to several different factors. One, just maybe general thermoregulation. We know that cold is a vasoconstrictor. When we have vasoconstriction of our peripheral vessels, it increases total peripheral resistance. So the heart's trying to squeeze out against that, hence an increase in blood pressure. When it's cold out, what happens? You're not outside as much. You're not sweating as much. So that sodium and salt, water, the homeostasis there is shifted. You're not losing as much plasma volume to sweating. So we tend to have more plasma volume, which is more that the heart, has to push and control. By not being outside, you're also not getting as much vitamin D. Vitamin D from that UV exposure, having it less in the winter months causes that parathyroid hormone to increase. And in reaction, then it leads to a complex process that includes vasoconstriction, again, increasing peripheral resistance. And then also, they're finding a component of sympathetic activation and hormone changes that occur during the winter months. All of this together means blood pressure tends to rise during those winter months. Here's the concern, and it's such a concern that this global phenomena has been recognized by the European Society of Hypertension, and they have a consensus group that is working to try and develop parameters and education and to try and get a better handle on managing this. What we need to recognize is our patients up north. These things are happening that they may or may not be aware of. Well, right before they come down to us in these southern states for their winter, which is, warmer down here than where they're coming from, what do? They go to their doctor, they get all their medications adjusted. Great. Theoretically, for some of these individuals, it's adjusted to that higher blood pressure. So now they come down here when it's hot. all of this flips. They're outside, they're sweating, they're hot, they're vasodilated, all of these things. Well, now they may be over medicated because naturally their blood pressure may be coming down a little bit. And some of these individuals actually are over medicated. One particular study looked at almost 700 people with hypertension, and they found that almost 14% of those individuals were able to decrease their medications just during the summer months. Even if our patients that are staying in the same area where there's a significant weather and seasonal change, we can see this happening. And then the flip is going to happen if they went to their doctor here and then they go up back up north. So we need to be aware of these, particularly as seasonal variations are happening more, because our patients may be over medicated. The most common medication that they found that needed adjustment was that diuretic, because it does change that plasma volume, and it relates to a lot of these regulatory processes. So that's something that when we see our patients, we should be checking their blood pressure to try and see if we can hone in on this. Masked hypertension, I've already briefly mentioned. These are the individuals who are normotensive or slightly elevated at rest. But when they're out of the office, they have different situations in their life. Maybe it is increased stress from interpersonal relationships, work, just general anxiety. Maybe their activity level causes their blood pressure to rise. Think of our patients, right? For many individuals, after they have an injury or a change in their functional status because of a disease process, they are having to work harder. So, what used to be something easy and not really cause them to be exerted, well, now they are. So, that's more sedentary individual that's moving, or that individual who had the total hip replacement, just doing their ADLs and showering may be a little bit of a workout for them. Think of our obese patients that we're now starting an exercise program with. Exercise tolerance has changed. They may not have hypertension, but that exertion raises their blood pressure. And then, of course, there are individuals who are smoking and using excessive alcohol that can increase their blood pressure. So during those instances throughout the day, they have episodes of high blood pressure. And the research is showing that for some of these individuals, when they have true masked hypertension, their blood pressure can increase between 50 and 65 millimeters of mercury from their resting blood pressure. And that damage is occurring to the vessels, that velocity change, that change in the rigidity of the vessels. And the target end organ damage, according to the research, approaches that of what happens to individuals with the same sustained hypertension. This is a group that we really have an opportunity to capture and get the help that they need to manage it. There was a small cohort study that looked at, well, how can we better recognize this, or kind of provoke it a little bit for diagnostic purposes in a controlled manner. And with 75 patients, they had them perform low level cycling, and they had them work just at 60 to 70% of their age predicted max heart rate. So not too intense for them. And they monitored their blood pressure. They just had them exercise for about 5 minutes. And they did find that a significant number of individuals, their blood pressure systolic level exceeded 175 millimeters of mercury from their baseline. And those are the individuals that we have concern of this masked hypertension. So we want to watch that. If we get that high value that we're kind of like, maybe I just measured that wrong, and you check it again and it's still high, you go through the evaluation that we discussed for target end organ damage, like, oh, it was just one episode. See if it's not just one episode, because it might be that masked hypertension that they need referral for. What should happen normally when someone is exercising, just to review what we're already aware of, these values, if it's not something you're assessing daily, it can get a little bit challenging to remember. Um, when we're looking at patients' response to exercise, assessing blood pressure response is going to give us a lot of insight into their hemodynamic stability. And it may even help us decide when there's early disease happening, like that masked hypertension. Normally, what should happen when someone exercises, we're going to see an increase in the systolic blood pressure, about 10 millimeters of mercury per metabolic equivalent. And then diastolic, it may increase less than 10 millimeters of mercury. We tend not to see much of a change there. If you look in the research, they say somewhere between 6 and 14 millimeters of change, if any, in that diastolic blood pressure for the individual. What happens is, if someone's exercising, cardiac output needs to increase to meet the demands of the tissues. And then we're going to recognize that if we're doing lower extremity exercise, those, whether it's exercise machines, specific, squatting, or activities that are really focusing on those larger muscles of the legs, we're going to have more vasodilation in those large blood vessels, decreases the resistance the heart has to pump out against. So we're not seeing as much of a rise in blood pressure when someone's doing lower extremity exercise. When someone's doing upper extremity exercise, we're going to see a significant increase because those are smaller vessels. And it's not going to kind of take that ease off of the periphery. So the heart is going to still have to pump against resistance. Whole body exercise, you tend to see the least change if you were ranking it and assessing patients, to their response to different types of exercise. In all cases post exercise, we tend to see a similar responses, that there should be a decrease in 10 millimeters of mercury per minute. So usually by 5 to 6 minutes post exercise, the patient should be back down to their resting values. An interesting phenomena that happens in some patients is post exercise hypertension. And we want to monitor for this specifically. So be sure to check that patient 5 to 6 minutes, and then check them, a couple minutes after that, just to see if they even dropped a little bit lower. What happens in some individuals, they're not exactly sure why it occurs. It has something to do with the cardiac output and stroke volume, how much blood is being pushed with each pump of that heart. They find that some individuals, their systolic and diastolic drop even lower than baseline. And as long as it stabilizes and then eventually returns, it's not a concern. However, this may be your individual where, if you see this occurring, it's a good indicator that exercise will be beneficial in their cardiac vascular program, their cardiac rehab, because it means that their body and their vasculature responds well to exercise, and it can have a real positive benefit for them. On the flip side, individuals have a hypertensive response to exercise in some cases. That exaggerated blood pressure response in individuals, that masked hypertension, shows that in the research, there's a 1 to 3-fold increase in the risk of cardiovascular events in these individuals, and in the risk of future hypertension, because that physiologic stress has an abnormal response. So these are the individuals that we're going to monitor for, where their peak and their baseline has a significant difference, and then make those outside referrals as necessary for additional evaluation. Hypertension, we know all the basics on monitoring: lifestyle, diet, exercise, many of the components we already discussed. What I'm going to highlight are some of the different areas that research is exploring. We know that pain can increase blood pressure, and we're all well versed in pain management. I'd just like to expand that to make this connection to sleep quality. That make sure with all of our patients, regardless of their diagnosis, that we are considering their sleep position. How much sleep are they getting? The quality of it. Is there something we can modify for them so they can have better quality sleep if they're in pain when they sleep, or they just can't get comfortable. The Pittsburgh Sleep Quality Index is a quick, easy assessment tool that can be utilized. Maybe we can look at positioning for the individual. Maybe some studies say just doing a little bit of a foot massage before sleeping allows an individual to rest. If they have sleep apnea and because of whatever their pathology is, they can't get the mask on and get in a good position, we need to consider that because it could have an impact on their hypertension. Um, they're finding that sleep deprivation has significant impact on hypertension, that deprivation of sleep increases sympathetic activity, it causes hypothalamus changes, it increases cortisol, and all of that leads to higher blood pressure. There was an interesting study that looked at massage, and small cohort, wish I was in as a study participant, individuals around 44 years old, females. They went for massages, hour massage 3 times a week to just the back and the upper extremities for 8 weeks. And they found that it decreased their hypertension significantly. And not only did it just decrease their blood pressure values, they looked at lab values and they found lower levels of C reactive protein that we know is related to the inflammatory process. So it's suspected to contribute to that vessel damage. So they saw benefits there. Not being cynical, however, if I got to take a break 3 times a week and go for an hour-long massage, I think I'd be feeling pretty relaxed too. But on the positive side, what to look at here is, again, maybe opportunities for our patients. If that massage is not covered or they can't afford it, maybe yoga, breathing exercises, something else to help relax might be beneficial. Neurogenic orthostatic hypotension is what we will look at next. So, orthostatic hypotension is when the individual experiences low blood pressure, and we're looking at a neurogenic cause here. This can happen in individuals with high blood pressure. It's a completely different mechanism that causes this episodic low blood pressure. Normally, what happens, we stand up. About 70% of our blood volume is going to drop into our lower extremity vessels because of gravity. That decreased venous return, cardiac output, and blood pressure unloads the baroreceptors, which are activated. Autonomic system responds, increases peripheral resistance, increases heart rate to stabilize that blood pressure. Great. That is what should happen. Patient's okay. Unfortunately, as individuals age, this response is dampened. That baroreflex activation is dampened, so the autonomic system doesn't always kick in, and there's an inadequate response. And individuals, when they stand up and have those position changes, systolic decreases greater than 20 and or diastolic decreases greater than 10. The individual can have an episode of syncope. It's not just that. To recognize it, this lack of counter regulation can also just lead to symptoms of maybe there's visual changes, that lightheadedness. The individual just may seem a little more confused when they first stand up. It's not just a syncopal episode to be aware of. In some cases, we need to consider why this is happening. The physician needs to look at it. Are they over medicated? What else is relating to it? And then that maybe volume expansion is necessary. We're looking at fall prevention. And then also the individual might need some type of external compression device, some type of stockings that helps increase that venous return. And also pools in the abdomen too. I was looking for a specific recommendation. Generally speaking, 15 to 40 millimeters of mercury of pressure on those compression devices or stockings is what's recommended. For patients just looking at first thing in the morning, something else to consider is their sleep position. While we're lying flat, there's in bed at night, there's increased perfusion that goes to the kidneys. That increases the processing of the kidneys. It's going to pull the fluid and volume and salt out of the blood to be excreted. That leads to a greater risk of hypotension when that individual stands up because there's later less fluid volume to the blood. So increasing that head of bed about 10 degrees, which is about 9 inches, helps regulate that kidney perfusion and can help accommodate and maybe diminish some of that orthostatic hypotension when they first get up. Counter pressure maneuvers that we'll look at next are using that total peripheral resistance to the benefit of this patient to increase venous return through isometric contractions. Individuals should be educated if they have this not to stand still for long periods of time, but that happens a lot. Maybe they're online waiting somewhere. They're waiting for the ride to come. They're standing doing their ADL care, and they need to learn different maneuvers if we're unable to modify those activities. So, the idea is to have that patient engage in different types of muscle contraction in order to increase that venous return and help facilitate the perfusion up to that brain and other organs. So for some patients, just as they're doing sit to stands, to have them do more of a gastroc, plantar flexion push may help as they're standing up. If they're up and they crisscross their legs and squeeze their legs together, research has shown that this can change cardiac output to a level that's similar to an anti-gravity suit. Head bending may seem counterintuitive because the person may be getting dizzy, but the idea is, again, safe and controlled. You have to pick what works for your patient. Bending the head decreases the hydrostatic column between the brain and the heart, so that may be enough to help with perfusion. Squatting, again, think safety, think the age of the patient. But when someone squats and kind of, bends knee flexion, this compression of the vessels is actually preventing the venous flow down into the distal leg, hence maintaining it going further back up. Toe extension is a real basic one, can safely be done for most patients. As they're standing and they extend their toes, you're going to get anterior compartment contraction, you're going to get posterior compartment contraction, and that may be enough. So you can look at different strategies, consider what's safest for your patient to educate them in. Metabolic syndrome is another condition that relates to cardiovascular risk for patients. We can't control everything. We can't control age and genetics, but we can influence other risk factors in this cluster of disorders that increases the risk of developing cardiovascular disease and type 2 diabetes. So the co-occurrence of these different factors leads to that risk. Individuals who demonstrate these different combinations of risk factors are at a twofold greater risk of developing cardiovascular disease over just the next 5 to 10 years. So we have big opportunities here. We know that changes in cholesterol levels is necessary. This dyslipidemia management, we'll look at how exercise can affect that. Blood pressure, utilizing exercise to control that. And then fasting blood sugar leads to changes in glucose tolerance that occur, and abdominal obesity tends to play a critical role related to that. When we look at abdominal obesity, females who have an abdominal measurement that is greater than 35 inches in our females, and then males, when they have a measurement that is greater than or equal to 40 inches, those are our individuals who are at a greater risk of cardiovascular disease. Here's why. We have a layer of subcutaneous fat, and that subcutaneous fat I am going to make orange. So that subcutaneous fat is here, it's between the skin and not intertwined with the organs. In blue, what we're seeing is that visceral fat, and that visceral fat is going in between the different organ structures, and that is going to create ischemia among those different organs, creating a hypoxia of the tissues that triggers an inflammatory response, macrophage infiltration, inflammation, and then it leads to different physiologic changes that increase blood pressure. We're also seeing that these adipokines, that are the cells in that visceral fat, they have many other different roles that go out in contributing to insulin resistance, to altering that renin, angiotensin, aldosterone system, that are our hormones that relate to kidney and blood flow and blood pressure, and then also that inflammatory and oxidative stress, those macrophage infiltration that all ultimately lead to hypertension, diabetes, and cardiovascular disease. If we're looking at managing cardiovascular disease risk for our patients, one factor we can look at and something objective that we can utilize is hip to waist ratio. The way this works is you're going to measure just under the lowest rib and then measure the widest portion of the buttocks, do your mathematical calculation. And someone who is a pair where they have wider hips to waist and that calculation comes out to zero point zero 0.08 or less, they're at a lower risk for heart disease or cardiovascular disease. Our avocado individual, where they tend to have a little bit wider in the middle, kind of closer measurement to their hips, they're at a moderate risk. And our big concern are for our individuals who have an apple shape. That is where that midsection is the largest for them. So when that measurement is greater than 0.85 for women and zero point 0.1 for men, that is indicative of that visceral fat that places someone at an increased risk. Metabolic syndrome, dyslipidemia, this combination changes those signaling pathways to increase that risk of cardiovascular disease, leading to this chronic inflammatory process. They're also seeing mitochondrial damage, free radicals, fatty acids being released that go into the bloodstream. And what we're finding is we really have an opportunity with exercise to have positive influences in these areas. And we'll look at during our next and last hour that different types of exercise can target different aspects of this in order to help decrease the risk for patients. That segues us into atherosclerosis. When we look at the pathogenesis of atherosclerosis, we know it is that progressive buildup of fatty plaques that is occurring inside the vessel. It contributes to decreased perfusion, especially to the heart, the vessels that serve it, the coronary arteries, as well as the vasculature that goes up into the brain. And when they're starting to investigate more what actually happens with atherosclerosis, It's about, well, why do those plaques form? What is leading to their development? And the culprit that is now recognized is chronic low level inflammation, tends to have that causative role. And here's how it relates to that dyslipidemia and that excess fat, that they're finding that low density lipoproteins, those are, if you want to call it, our bad cholesterol, they are going to be transported through the endothelial layer. So if we look on the left here, they're actually going to kind of get into that inside layer of the blood vessel. What happens when they get in there is the endothelial layer starts to become dysfunctional because that fat shouldn't be there, and it makes it more procoagulative. It is going to form these bulky complexes as those LDLs oxidize in that inside of the blood vessel. So now this has happened, and the body is going to try and protect itself. It's going to try and heal itself. Immune response happens. Macrophages are going to come in. Those scavengers are going to try and clean out this fatty tissue that shouldn't be located inside of the blood vessel in order to try and protect it so it can do its job of perfusing. So as the macrophages engulf these molecules of fat, when they look at them histologically, they become what's called foamy macrophages, that they have a specific modification from absorbing these oxidized LDLs, and they have actually lipid droplets located in them that form this, what they call a foamy appearance inside. Well, now you have all these different complexes and processes going on, and everything just continues to adhere to it. And that's where we have that plaque happening. And this vascular injury causes this vessel diameter to decrease in certain areas where this is happening. It becomes a persistent response because the more molecules of the fat keep adhering on, body keeps trying to protect itself, etc. This idea of that chronic low level inflammation that happens because this process perpetuates is significantly recognized in the research now. There was research that looked at the research, of course, and one researcher said, how much more is this theory being examined and being identified as causal in nature? So they went between 1970 and 1990, and they pulled all the articles that utilize different search criteria related to inflammation, atherosclerosis, and variables of that. And they were able to pull a whole 80 articles during that time period. And I can attest to that. In the 80s and and 90s, I was in school and didn't really hear much about this, if any. And then he redid the study with the same search criteria, looking between 2010 and the current time period, found 12,000 articles utilizing those search terms. So it really is recognized as a powerful contributor. try and gain more information, research is also looking at, well, how can we medically identify this process and have more insight into it earlier on? So, what you're probably going to notice if you're in have the opportunity to work with the cardiologist or see the lab values for your patients, or again, maybe it's an opportunity here for relationship building and um, to become more comprehensive. We know C reactive protein, we're all familiar with that already. It is that inflammatory marker that we see in our patients with many different diagnoses. Well, usually those levels that we're looking at of C reactive protein are going to be greater than 10 because it's indicative of inflammation somewhere else in the body. But what they're looking at now is saying, well, if we want to look at inflammation specifically in the different blood vessels, we actually need what's called a high sensitivity C reactive protein level, where we need to look at lower levels, seem to be indicative. Kind of that threshold is lower for when it's happening in the blood vessels, that chronic inflammatory state. And what they're finding is someone who's above 3 on the high sensitivity test, those are individuals who are at that greater risk of developing cardiovascular disease, where they have a greater risk of CVA, myocardial infarction, peripheral arterial disease. So they're finding what actually led to looking at this, there was large study global registry that looked at individuals who had coronary events and those that went in for revascularization procedures, and then the incidence of additional events. And they found that even 5 years after revascularization surgery, whether they had a stent or a bypass or some other percutaneous procedure, over 20% of the individuals had recurrent myocardial infarctions. So they're like, okay, something else is happening here. How can we quantify maybe that chronic inflammation? And it led to this testing here. So you might start seeing this kind of testing becoming more standard to give information. In terms of the clinician deciding how to manage the atherosclerotic cardiovascular disease for patients, the tool is the ASCVD estimator, where the physician is going to put in all the patient's age, genetics, race, their lab values, smoking history, diabetes, all those different variables that increase the risk of cardiovascular disease, and it's going to forecast their 10-year risk of having a cardiovascular event. And then it gives them percentages. There are also tools then that lets the physician go in with the same data and pick different interventions. Well, maybe I'm adding this particular medication and I'm adding exercise and I'm taking out if I get them to quit smoking, and it can recalculate their risk to see how those different changes can positively influence, and that helps come up with the treatment planning. So if this is something that you can gain information on, it might be interesting, particularly if you're working with this cardiac population and your goals are related to managing the cardiovascular disease, might be additionally helpful to help you target your interventions. Which brings us to how are we going to accomplish that? I've mentioned several times that exercise has shown to have benefits for individuals. Several different research studies have specifically looked at this. Individuals who underwent revascularization procedures, either percutaneous or CABG, they followed them 6 months and 12 months post-operatively through a systematic review, and they did find that there was a benefit of exercise to quality of life for these individuals. Those individuals who just had stable angina, that participated in biking, walking, some kind of casual exercise, even just yoga, they did find that there was an increase in fitness level. And the ACA does recommend participating in exercise to increase exercise capacity for these individuals. They did say that there weren't a lot of great research studies for this population, which is why they may not have seen a strong correlation. And I do like to present all the research that's there, not slanted one way or the other. Looking at individuals with acute myocardial infarction, this is interesting. When we look at being comprehensive in addressing our patients, and there is so much more discussion on mental health and its role on overall well being and quality of life for individuals, this was a meta analysis of 20 different studies where they looked at individuals across different countries, Canada, United States, China, Iran, Netherlands, because you wonder if stress and anxiety is that specific to certain countries and lifestyle. They looked at individuals midlife, 52 to 60, mid 60s, I can't remember the number, and they found that those individuals who participated in exercise had decreased levels of anxiety and depression. And this is important for patients post myocardial infarction because we know that those different emotional responses can be triggering events for myocardial infarction. And maybe some of our patients, where we're looking at motivating them, if they're like, well, I don't need to lose weight, I don't need to get muscles, maybe they're a little resistant to it. Maybe we can tackle it from the mood and socialization angle. Not that we're diagnosing either of these conditions, but maybe it's another in for them. Examining individuals who did have a major adverse cardiac event is what we just looked at. What about prior to that individual having a heart attack or having a stroke? When we know this endothelial dysfunction is happening, the plaques are forming, and it can ultimately lead to atherosclerosis and heart attack or stroke. What about catching them sooner? And when we look at developing exercise programs, like we know for so many diagnoses, there's no cookie cutter, so I can't give you a specific protocol. But my hope is by highlighting the benefits from these different research studies, you can pick what fits your specific patient. And then it really is about modifying the interventions to something that your specific patient will actually participate in, and then adjusting it to be within their max heart rate value, to be within their particular level of exertion. Because for some patients, moderate intensity aerobic exercise, that may be walking to the bathroom, depending on how compromised they are. For other individuals, that might be a 30-minute workout at 4+ miles per hour on the treadmill. So we're going to look at making those modifications patient specific. What the research shows is for individuals who have hypertension, moderate intensity exercise did actually improve the ability of the endothelial layer and the vasculature to vasodilate. These were individuals who just did 30 to 40 minutes of moderate intensity exercise, kind of mixing that walk run, 3 minutes of walking to 2 minutes of running at their intensity to reach a 50% VO2 max, that it did change the ability of that vasculature to function. Our individuals with pre or elevated, so they're a little less compromised, participated in vigorous levels of activity, looking at 65 to 80% of their max heart rate, 45 minutes, 3 times a week. Again, vascular benefits were recognized. And then they looked at cohorts where they did either isometric or dynamic types of resistant training. And the thought is that resistance exercise doesn't and shouldn't be avoided for individuals with cardiovascular diagnoses, because the ischemia that happens when the muscle contracts around the blood vessel and then releases, that reactive reperfusion is creating adaptive changes and changing the velocity inside the blood vessel to increase its ability to vasodilate and vasoconstrict, that is showing carryover. How about that lipid profile? We said that exercise does have an opportunity to change lipid profile for individuals. And I put the reference here for this study because it's really interesting. Just giving you a superficial idea related to it, but sometimes we do have the opportunity to see these different lab values and really be specific in targeting our exercise program. And they found that individuals who had myocardial infarctions, CABG, the percutaneous procedures, stent placement, um, for the angioplasty, they looked at them and looked at their lab values based on what type of exercise they engaged in. And they found that the relationship of exercise volume, so taking how long they exercised for in each session and how frequently they did it for how long, came up with an exercise volume, right? Kind of like look at reps and sets. And they found that individuals who participated in 120 to 180 minutes of exercise per week, and they did this for 13 to 24 weeks, that aerobic and resistance combination really impacted the HDL and the triglyceride. Whereas the individuals over 0 to 8 weeks time period who did greater than 180 minutes a week, so more intense, it took less but less weeks, they really seemed to see a difference in their LDLs. So it's interesting to see that those individuals who did that moderate, longer term exercise, walking, running, cycling at the 60 to 85% max heart rate, that those individuals saw a different outcome than those individuals who were doing resistance training, bridging, bench presses, hamstring curls, rowing, lap pull downs, at about 60% of their 1 rep max. They saw a difference. So I just thought that was really interesting if you want to look at that, if you wanted to even get more specific. But at minimum, we know we're influencing these factors. Atrial fibrillation is the next condition that we will discuss. This is the most common type of cardiac arrhythmia that occurs in individuals. It is that irregular contraction of the atrium that leads to altered filling of that ventricle. If that ventricle doesn't fill appropriately, then the volume is not there to be ejected out to meet the metabolic and oxygen demands of the body. So the individual is then going to experience, I mean, some individuals may be asymptomatic. Other individuals might experience that tachycardia that they describe as their heart palpitating, shortness of breath, low blood pressure, diaphoresis, dizziness, different symptoms. As we look at the fact that that atria is not contracting smoothly, so that ejected into the ventricle and then out the body is not smooth, we have different movement of the blood in the chambers that makes it more prone to clot formation. And then those clots, when they break off and are propelled, can lead to stroke. It can lead to heart failure just because the heart is having to work, ventricles are trying to work harder to actually push out less volume each time to meet the different demands of the body. That turbulent blood flow is what causes those blood clots that can lead to that potential stroke. As we look at individuals and how they're going to be managed with atrial fibrillation, some individuals are going to need cardioversion. They're going to need different interventions, maybe medication, in order to restore that normal sinus rhythm and normal contraction and filling and passing of the blood flow. This can happen through many different mechanisms. As we look at the medications that are utilized to manage patients who present with arrhythmia, the American Heart Association, American College of Cardiology guidelines are what I have posted here. There's one category of medications that we're all well aware of. If we look at those anticoagulant medications, this is going to be our vitamin K antagonists that might be utilized on someone who has mitral valve stenosis or a valvular heart disease. This particular medication, warfarin would be an example. Our 9 vitamin K anticoagulants ends in the X band. These are the medications that are going to target more specifically to inhibit prothrombin in its final pathway before it leads to that clot formation. These anticoagulant medications, they are good at preventing the clots. However, the concern here is increased bleeding. Another category of medications are our antiplatelet medications. Aspirin, that is commonly utilized. P2Y12 inhibitors, clopidogrel is an example. Those work through a different mechanism. They're going to focus more on platelet aggregation to not get too deep back into the pharmacology of college. They prevent ADP binding in the final pathway related to platelet aggregation. So these work through different mechanisms. These have less bleeding risk, but they may not be as effective. So, some patients are on either double or triple play where they have different combinations of these medications. So, when you look at your patient's medications, and if you see, well, they're using multiple, someone on double play might be that person who has had a percutaneous stent that's been placed for coronary artery disease, and they're trying to prevent a secondary myocardial event. Someone on triple play, they have even greater concerns about clotting. They're going to be at a much higher risk of bleeding. These tend to be used more short term for patient management. As we look at managing the bleeding risk factors for patients who are taking the different types of anticoagulant medications, there are many different factors that contribute to that risk of bleeding. There's actually been a shift in approach related to the use of anticoagulation medications. The current thought is that medication levels need to be sufficient in order to decrease that risk of thromboembolism and ischemic events, but it needs to be balanced with avoiding GI bleeding, intracranial bleeding. And the primary method in order to avoid that is accurate medication management. The what we're looking at here is called the anticoagulation evaluator. It compiles different risk factors. It's from the American College of Cardiology. The physician utilizes this to look at the different risk factors and then work to manage that bleeding risk for the patient. There are, of course, those non modifiable risk factors: age, the disease process, if they've had a stroke or bleeding history in the past. What's also included here is a labile INR. We know that this is going to be monitored for patients to make sure the medication levels are appropriate. And labile is considered when that individual, less than 60% of the time, is in that value of 2 to 3 for their INR. Um, if they're not in that predictive range, it's considered labile. And I know this is under a non modifiable risk factor. And believe me, I am not disagreeing with the ACC. I just like to sometimes consider things differently. If a patient has a labile INR, maybe in rehab we can consider, are there other factors that are contributing to it that we can positively influence? For example, is the patient able to go for the appropriate testing? Like physically, are they thinking, well, you know what, it's just too much for me to go out. I'm skipping this month to get my blood checked. Do we need to look at transportation, car transfers? Is there a financial burden? Outside resources maybe need to be referred for that patient. Does the patient have visual impairment, dexterity impairment, where if they need to administer themselves or swallow the pill, do they have appropriate positioning? If they've had a stroke, are they able to swallow? Do they need a speech referral? And additional testing. So, other things to think about that maybe we can have a positive influence on to help keep their level stable. Looking at uncontrolled hypertension, we know that through exercise, we are able to have a positive influence in that area. There is the research shows that there's limited evidence on the direct effect of exercise on atrial fibrillation, but we know the positive effects on hypertension that kind of rolls into AFib management. Also, just being aware with our patients when we know they have other conditions. Looking at other medications that they may be taking to look for opportunities to make sure they're referring back to their physician and their pharmacist to make sure they're not mixing medications. Fall risk is something we are directly involved in, looking at vestibular, looking at balance, strength, etc. Um, and then also monitoring that patient for those signs of renal disease, liver disease, looking at their skin, their eyes, if they have a darker complexion, for any of that buildup of that bilirubin through the identification of jaundice. Patient education is a critical part of rehab for individuals that have atrial fibrillation. And this is whether you're treating them for that as their primary diagnosis, meaning you're seeing them from cardiac rehab, or if they have atrial fibrillation as a comorbidity, along with maybe that sprained ankle or rotator cuff repair that they just went through, because we're asking the person to participate in more activity than maybe they were previously used to, and that they may be comfortable with given their history of atrial fibrillation. The typical concern is that patients who are on blood thinners, those antithrombolytics, if they have a fall, they're concerned they're going to have a intracranial hemorrhage or a brain bleed. Well, again, just like there's a shift in the management, there's a shift in the theory of the benefits of mobility for this patient population. And the terminology that is used now is to fear the clot, not the bleed. Obviously, we're not going to put it that frankly to our patients, but for us to recognize it, that the current school of thought is that someone who is on anticoagulants, that they need to be participating in activity. They need to be taking their anticoagulant medication because the benefits of this heart healthy lifestyle that we've been talking about is going to contribute to their hypertension, their atrial fibrillation. Those positive benefits, being up and moving, outweigh the risk of an intracranial bleed if they happen to have a fall. Because we know if they have a stroke or a heart attack, what's going to happen and the potential devastating effects from that. So, we're also just not thinking when we monitor these patients about avoiding risk of fall for them. We also need to be aware that when we increase their activity level, that as we're asking them to exercise, that because of the anticoagulants, if we are over exercising them too quickly, there is a risk of the development of compartment syndrome in the muscle groups where we are working. So we do want to be cautious of that. We're also monitoring our patients for changes in vision, because there can be intraocular bleeds that might occur. Research looking at patient education for individuals with atrial fibrillation on the different types of blood thinners, it's really showing that most patients, they are just afraid to move. They think that because they're on these blood thinners, they can't do anything, and we know that that's not true. It needs to be done safely, appropriately, and there are more benefits to mobility. Also, something that's come out in the research is that patients think that the diagnosis of atrial fibrillation is immediately life threatening. Now, while some of the consequences may be, that diagnosis itself, we know can be safely managed. Like, daily activity is better than being sedentary for life after the disease has been diagnosed. So, something to bear in mind in how to slant your patient education. Looking at some of the advances to help with the monitoring of patients with atrial fibrillation, there are different apps that work on some of the smartphones that are being developed that look at using a camera based application where the tissue perfusion is going to be assessed for the individuals. They are finding that those types of devices do tend to have more false positives in healthy individuals. However, there was one study that looked at small cohort, 24 individuals post operative surgery, and it did correctly diagnose episodes of atrial fibrillation in 4 of the 24 patients post-operatively. So the research is coming along there. The challenge with atrial fibrillation, as we know, is that it's episodic in its nature. 20% of atrial fibrillation induced strokes by individuals are in patients who are undiagnosed even with that atrial fibrillation. That tells us that they could have been prevented if there was other recognition of that, which is where all these smartphone apps and modifications come from. One that you may have seen is this type of device. It's a portable single lead electrocardiograph where the individual places their fingers on it. It is connected to an app on the phone, and it's going to read the perfusion as well as, I'm sorry, not perfusion, it's going to read if there are any events of atrial fibrillation that is occurring for the individual. So the research is coming along with these devices. Obviously, they're not a substitute for medical consultation, but maybe it'll give some patients peace of mind, and it may help them in affirming their symptoms and kind of learning what they're feeling and getting kind of a visual as to what may be going on with their heart and getting immediate feedback as things are happening. Moving on to heart failure. Heart failure was formerly referred to as congestive heart failure for left sided and then core pulmonare for right sided. Now it's just referred to as heart failure, and then we'll look at the different classifications of the disease process. Overall, this is going to be that chronic, progressive inability of the heart to produce enough cardiac output, enough push of the blood for functioning of the extremities as well as the organs to meet those metabolic demands. There can be many different etiologies as to why someone would present with this. The ones where we have been discussing today that we can be impactful in our rehab is looking at hypertension, coronary artery disease, metabolic syndrome, and then also we know diabetes. Exercise can have a positive benefit there. Um, there are many other diagnoses that can lead to the development of heart failure for our individuals. Regardless of the etiology, the classification systems that are utilized are going to look at either a structural classification or a functional classification of heart disease. We know that the condition is associated with a wide spectrum of functional and structural abnormalities. It's significantly impactful for the individual who has this diagnosis, as it is for all the conditions we're talking about today. And maintaining long term stability for someone who has heart failure tends to be challenging because it is so multifaceted. And they do have significant physical limitations that can contribute to the decreased quality of life. So, we're going to look for as many opportunities as possible to get these individuals into rehab and educate them on how they can have positive changes in managing their condition. To first do that, we need to understand physiologically what's happening. So, when we look structurally, we're looking at the actual heart, and then if the left side or the right side of the heart is not functioning appropriately, or both. And then, in terms of the functional classification, it's going to look at that ejection fraction, that um, amount of blood that is going to be pushed out with each pump of that ventricle to meet the demands of the body, whether it's still achieving that ejection fraction or not, despite the structural changes. Taking a look at the pathophysiology of left-sided heart failure, we know when we look at the left side of the heart, we're looking at that oxygenated blood that has come into that left atrium and then the left ventricle from the lungs that's going to go out the aorta into the body. What happens is because of some type of left ventricular pathology, this left ventricle is unable to eject sufficient blood out in order to meet the demands of the body, whether that's because of long-standing hypertension, where it's had to work so hard against peripheral resistance, or it's some other disease process, because it can't get the blood out of that aorta, it is going to back up into that left ventricle, then back up into that left atrium, and then back up into those lungs for the individual. As that blood is backing up into those lungs of the individual, that is going to cause that pulmonary congestion in the vasculature, that pulmonary edema. And because of that extra fluid there, this is that individual that is going to present with dyspnea and coughing, those classic symptoms. Augmenting this process, unfortunately, are going to be renal mediators, that there's going to be increased retention of sodium as well as water. And we know that increases the blood volume more, which only puts more strain on this left side of the heart that is already struggling. Right sided heart failure, these are going to be individuals that are going to have some type of valvular dysfunction. We're looking at the blood coming into the right atrium from the periphery and then into that right ventricle that is eventually going to go out into those lungs. Well, if this individual has a pulmonary pathology where the blood can't get into those lungs, or these individuals have some type of valvular pathology, it's going to cause backup into that right ventricle, back up into that right atrium, and then back up into that peripheral circulation. In this case, what we're going to see is edema in the periphery. It tends to be bilateral in nature, tends to be pitting in those bilateral lower extremities. We may also see ascites in the individuals because of that venous pooling in the abdomen with that distension. Pleural effusion may be present. And if you examine the patient that has significant right sided heart failure, you're going to see this. Jugular distension, and it's going to be right in between these two lines that I drew here. So you want to again be looking up in this area of your patient, and that'll be that hallmark sign, some of these hallmark signs of that right sided heart failure. What happens is one can lead to the other, and the individual can become acutely decompensated. So, that individual who has that left sided heart failure, where it has backed up from the periphery into that left ventricle, into that left atrium, and now it's backed up into these lungs. Well, now when the right side of the heart tries to pump the blood into these lungs, it can't do that. So it's going to back up into the right side of the heart, back up into the periphery. And this is that individual where we're going to see pulmonary and peripheral symptoms where they're acutely decompensated, unfortunately. When we look at the functional classification of heart failure, this is going to examine, despite all those structural changes and all those symptoms that the individual may be experiencing, can the heart still function enough on diagnostic testing when it's examined to push enough blood out? So, if the heart is able to preserve the ejection fraction and still deliver enough blood out to that periphery, this is going to be when the ejection fraction is going to be for the individual greater than 50, somewhere between usually 55 to 70% is unaltered. So, as long as they're staying above 50, this is when usually there's a problem of that ventricle is just not filling enough to have enough to push out, but it pushes out enough to meet the demands of the body. On the other side, patients that do not have sufficient ejection fraction, where they have a reduced ejection fraction, these are the individuals where they're at less than 40% of the blood volume being pushed out into the periphery. And that's where the heart is just not able to squeeze or push enough in order to deliver to the body. What we're going to be able to gather information from, if you do have that ability to get more details about where is your patient in terms of their progression of their heart failure, is looking at the classification that's assigned to them by the cardiologist. And there's two different classification systems. One is from the ACC-AHA, and the other one is from the New York Heart Association. Looking first at the one from the ACC-AHA, this classification, it's linear. It looks at the progression of the individual with unfortunate progressive deterioration. So it's more from a structural perspective and a symptom perspective, that is staged based on the extent of damage to the myocardium. It represents irreversible changes, unfortunately. So, someone who's stage A, that's an individual who has no structural changes, no symptoms, but for some reason we know they're at increased risk. Someone who's at a stage B, this is going to be our individual where there is structural heart disease that is noted on different imaging studies. Maybe they have a left ventricular hypertrophy that is diagnosed, or a prior myocardial infarction. But generally speaking, they're asymptomatic from the symptoms that we have discussed. As an individual progresses down to stage C, this is the individual where we're seeing left ventricular filling inappropriately or insufficiently, dyspnea on exertion, fatigue, decreased exercise tolerance. And then stage D are going to be those individuals who may even have those cardiac symptoms when they're at rest. And that's the individual that is going to be needing maybe a pacemaker placement or a ventricular assistive device placed. The New York Heart Association classification is a little bit different. It's going to look at the symptoms the individual presents with, and it's also going to look at patient activity level. So, because it's combining so many different pieces of information, this is the individual where there you can kind of see movement, functional capacity, and I'm just briefly going to explain it. I have the link here if you want to look at it more in depth. This is what tends to be utilized more in the research. So if you're reading different studies, this would be a resource for you. um, that the functional classification is Roman numerals. It's looking at 1 through 4, from no limitation to an individual who has, just with normal activity, fatigue and dyspnea on exertion would be someone in a level 2 to someone who's severely compromised. To that, it's going to add letters A through D, looking at the symptoms the individual is going to present with. And as we go closer to that letter D, it's someone who has more severe cardiovascular disease, where they're going to need more specific ADL support, outside referrals, more progressed disease process. Biomarkers that are utilized when someone presents with dyspnea, the physician needs to make a determination as to, well, is it their heart failure or is it something else that might be causing this? And the biomarker of brain natriuretic peptide, BMP, it was originally recognized in the brain, but what they actually know now is that this is going to be released by the myocardium, and it's a compensatory mechanism that when that heart is struggling to meet the demands, this will be released to try and create some vasodilation in the periphery in order to decrease blood pressure. It's going to cause the kidneys to excrete more water to try and decrease the blood volume. It's kind of like a natural defense mechanism. So, someone who has a level of this that's low, the physician would tend to think, that it is not heart failure that's causing that dyspnea. Whereas someone who is looking at higher levels, this is someone who it probably is related to their heart failure, because it means that that heart is releasing this BMP to try and compensate. Moving on to exercise tolerance for our individuals who are presenting with heart disease, there are many different causes of heart failure. Ultimately, how the individual presents, the systemic illness that they're experiencing is going to be very similar. Multiple systems will be affected. And usually, when we consider someone with heart failure, yes, we are thinking of that exercise intolerance. But what does that really mean? It's not just that they are endurance fatigue from a respiratory standpoint. That is true, that they are respiratory compromised. Part of that is that the respiratory muscle function has changed for these individuals. In addition to what we've already spoken about with the pulmonary edema, if we look at the actual inspiratory muscles, what they're finding is despite constant activation to assist this patient with breathing, those muscles are going to switch from more of a fast twitch kind of power fiber to more of a slow twitch fiber because they're constantly struggling. And overall, this decreases that ability, complex muscle changing process that goes through there. But that's something for us to think about, that actual respiratory muscle training is an important component of rehab. If we also look at that low aerobic capacity, a part of that is the generalized fatigue from the decreased oxygenation, the decreased metabolic demands being met. Another component is looking at peripheral muscle strength. What's noted in individuals who have heart failure is that there tends to be impaired oxidative metabolism that's occurring. There's an inflammation and a presence of the different cytokines that are pro inflammatory. And these individuals tend to have more of a low muscle bulk in their bodies. So we tend to see muscle wasting, deconditioning, unfortunately, that these individuals are experiencing from so many different aspects that are affecting them. They actually have found that there's mitochondrial changes in their peripheral muscles that contributes to a direct muscle fatigue. So we also need to directly work on that. So we see three different aspects here already of goals we can create in rehab and different types of interventions that we can be performing. Also consider for these patients, because of their lower activity level, it may be increasing their risk of osteoporosis from inactivity. So we want to make sure we're mindful of that in developing our exercise programs. So when we look at heart failure management strategies, again, if we're treating something in cardiac rehab because of their heart failure, or if we're treating someone for another diagnosis, maybe they have had a stroke, maybe they have multiple sclerosis, maybe they have a problem when they had a total knee replacement or a scope. We need to be mindful of all these factors to consider all the comorbidities when we're developing our exercise program. So, for all these conditions, maybe we can double dip a little bit and have benefits in many areas. So, looking at the different stages, if we are treating someone directly for their heart failure, stage A, we're looking at those comorbidities, risk factors, general health and wellness, what we talked about earlier in the course. Stage B, we're going to do all that along with more targeted strategies for pharmacologic management. Look at cholesterol, look at blood pressure, preserving ejection fraction through better exercise. And then when we look at individuals in the later classes, we're looking at those maybe patients we're seeing post surgically. Consider that for many of individuals with heart failure, a sleep study might be performed. We want to assess sleep quality and maybe make that referral, for the physician to look into that, because they are finding that many individuals do have sleep apnea. There seems to be a high incidence of correlation in that case. Don't forget the benefit of social support. This is going to help provide a buffer to help modify stress for the individual. If they have good social support systems, help promote adherence with their exercise program. And they have found that individuals that have good social support structures, they have less hospitalization and less mortality risk. And that social support, that might be from whatever type of exercise program or activity that you're having them involved in during and then post discharge. In terms of knowing when it is safe for someone to exercise and actually having the patient assess themselves on a daily basis, just to know it's okay to go through their daily activity. The heart failure zones are important to educate the patient on. I have these written in terminology for us, clinical terminology, but there are versions that can be given to the patient as kind of like a checklist that they would do each morning. And we can do this before we go into our rehab sessions with them also. Someone who is at a green level, this means they have no new or worsening symptoms. They're checking for swelling. They're looking at their lower extremities. We're assessing that. No chest pain. Their weight is remaining stable, and they are going to be able to exert themselves and go through their activities. Someone who is going to be in that yellow zone, this is that individual where maybe they're starting to have that dry cough that's being indicative of some pulmonary congestion starting. They're starting to have some shortness of breath. The weight gain, it's greater than 2 to 3 pounds in 24 hours. However, we want to also consider that if it's greater than 5 pounds in 1 week, because someone may have, oh, I just have a 1 pound increase today, but then maybe 2 days later, it's a 2 pound increase, but they use the value after the 1 pound increase, and you can see how that can kind of roll forward to them missing the weight gain increase. And we want to make sure we're documenting that appropriately also. Peripheral edema, ascites in that abdomen. The individual may start having orthopnea, where they're saying, well, I'm starting to sleep on some more pillows, or when we look at that sleep position or sleep quality, those are the individuals that we need to be cautious of and refer them back to the physician for management. Someone who is in that red, this is that immediate medical alert concern. They're having that frequent cough, that hacking. Even at rest, they're short of breath. The cardiac and metabolic demands can't be met. Again, that significant weight gain that we're seeing. We might start to see cognitive changes. This isn't just confusion or forgetfulness. The individual may be sad. They may just appear depressed. They're not eating. And this is that individual that cannot lay flat. So if they are unable to lay flat, that they're sitting up all the time, sleeping in a chair, this is another indicator that we have a significant concern where they need immediate medical management. They may be decompensating. As we look at the different interventions to perform for individuals who are presenting with heart failure, we're going to encourage overall increased physical activity within comfortable levels for that individual. As we consider the American Physical Therapy Association and cardiovascular and pulmonary section recommendations, aerobic exercise training is recommended for individuals with heart failure, and high intensity interval training. That is something that can and should be used for this population who are stable. They can work up to 95% of their peak heart rate. In total work each session, they might be doing, again, working up to 35 minutes or more 2 to 3 times a week. Again, for some patients, that may just be doing body weight exercises. For another patient, we might be having them on machines using more resistance. For someone else, maybe it's TheraBand. We're going to be looking at what's tolerable for them. And again, when we tell our patients we're going to be exercising, it for many of these individuals, their vision of what exercise is going to the gym for 2 hours that they think is out of their reach. But we're going to explain that it's to their level, that resistance training that we're going to do. We're not going to forget that inspiratory muscle training, there are different devices that can be utilized to give that resistance to those respiratory muscles. What's typically recommended is the individual to do a total of 30 minutes a day of the respiratory training exercises, 5 to 7 days a week, and the device should be sent to greater than 30% of their max inspiratory pressure if you're using one of those devices. To tackle that muscle wasting, electrical stimulation, quads, glutes, hamstrings, gastroc, combined with functional training can help change those muscle components and those fibers, working on those satellite cells that help build muscle through the electrical stimulation. Minnesota Living with Heart Failure questionnaire. This might be beneficial to help you determine exactly what activities are compromised for the individual so you can prioritize things and gear your exercise program to make it more meaningful for that individual so that they are more likely to participate in that program. And this is important that exercise adherence, educating the patient that they can exercise safely, how it's going to help them, getting their buy in, having them being part of it. Because the data shows that only 10% of patients with heart failure are even referred for cardiac rehab. Of those patients, only 3% actually attend. So we're missing these individuals. Opportunity here if you're looking for ways to get patients in and assist them. And this is important because they're finding that there is a high incidence for individuals with heart failure of rehospitalization within that first 30 days. That is so critical. If there's an opportunity for relationship building from that acute care discharge to that home care and that outpatient to grab these patients, the benefits are shown of exercise based rehab for individuals with heart failure. That one study looked at individuals who were decompensated, and it was a large cohort study. They had them participate in working up to 60 minutes of exercise 3 times a week. Um, they went through that for their 36 outpatient sessions of cardiac rehab, and then they went for a 3 month follow up back at the clinic. In between there, every month there was a phone call, from therapy, just checking in on the patient, seeing how it's going. And they did find in these individuals that there was not an increased rate of rehospitalization. It was safe for them to exercise under controlled conditions, and they did have better overall function. Looking at that reduced and preserved ejection fraction, this study looked at individuals on the New York heart failure scale of a 2 to 3. So they were mid progression, moderate disease. They did find that while there was no difference in mortality between those patients 12 months out who exercised versus did not, there was improved quality of life and less rehospitalization for those individuals. And then also, again, increase exercise capacity. So decreased hospitalizations or no difference is showing that it can safely be performed. One of the studies found that specifically looking at endurance for patients, it doubled. And that sounds, wow, it doubles. We need to quantify that. And when I look at these studies, I want to give you the actual data so you can use it appropriately. It doubled from an average of 0.11 seconds for the individual to 0.22 seconds. Now, while that might not sound like much of a change, if you've worked with this population, the fact that they doubled their endurance in small amounts of change, I forget which activity that specifically was related to, that is significantly positively impactful for motivation and quality of life, and then we could build from there. Cardiac resynchronization therapy is utilized for some patients where they're going to have that biventricular pacemaker that is implanted in order to help coordinate the functioning of the heart in order to control those electrical impulses. What they're finding in the research is that it actually causes structural changes in the heart muscle, also, that there's left ventricular remodeling and healing that happens. There's less mitral valve regurgitation, as well as improved injection fraction that leads to all of these other positive benefits. In terms of exercise capacity, they find that these individuals have an increased 6 minute walk distance, a better peak VO2 levels, increased total exercise tolerance time. So they're seeing benefits beyond just the physical leads and mechanics of it in terms of assisting the patient. What we need to be aware of is the individual's going to have the device that is going to be implanted into their thoracic cavity. So immediately post-op, we're going to be avoiding those upper extremity exercises. Lower extremity is okay. And what's really important is that if there is a defibrillator component, a cardioversion, we want to exercise the patient below that threshold level. So we need to know the pacing of the ICD and know the shock threshold to make sure we are working that patient below it. And then also, patients feeling better, they want to get out. We have to be cautious with driving. Some states have specific laws related to this. We have to be aware that if cardioversion is happening, that patient may be having a syncopal episode. Is it really safe for them to be driving? As we look overall at the benefits of cardiac rehab, we know that cardiac rehab for all of our patients that we've discussed today is looking at that multidisciplinary approach for our patient. It's PT, OT, speech might be involved depending on their diagnosis. We need to be mindful that if someone has had ischemia from any type of cardiovascular event, even if it is not a stroke, their cognition may be impaired, that those frontal and temporal loads may be involved secondary to cardiac arrest. So our assessments should include memory, cognition, so that we're educating them appropriately. IADLs should also be assessed, looking at more complex tasks, shopping, meal prep, those cognitive demanding tasks for that individual. There are many different resources available. The TCART initiative, this is through the Agency for Healthcare Research and Quality. They have many it stands for take stands for training, awareness, knowledge, and engagement. They have different resources available. And then the Million Hearts Initiative. This one is through the CDC and CMS. It's their initiative to prevent 1 million heart attacks within the next 5 years. I have included links to their different resources. What they have found is every day that a patient waits to enroll in their cardiac rehab program that they've been referred to, they're 1% less likely to actually do it. They've also noticed socioeconomic disparities that individuals who make greater than $75,000 a year are 2 times more likely to participate in a cardiac rehab program. Individuals who live outside of a metro area are 30% less likely. So, access, availability might be an issue. The benefits of activity, we know we've discussed them already. Looking at monitoring activity for individuals, accelerometry is important, and it's able to give us information on how well patients are responding. There have been a couple of different studies that have looked at patient participation in activity. And what they're finding is that individuals who are participating in exercise programs, it is going to carry over that increasing weekly physical activity, decrease new cardiac events, which makes sense with everything that we have discussed. That even if it's just walking, keeping people up and moving has benefits for them in the long term. When we look at general health and wellness and promoting cardiac programs, for all populations, how intensely should someone be exercising and how often should they be performing activity? We're going to look at metabolic equivalents. Don't have a horrible flashback to your rehab course in school. Metabolic equivalents, just refreshing on that definition. It really just is. I mean, and now it makes so much sense. I remember studying this for hours back in school. If you're sitting quietly, like maybe you are participating in this course, you're going to burn 1 kcal of energy per kilogram of weight per hour. That's basically what it is. Then, when we look at activity levels, it's comparing that as a ratio, that how much harder than that one are you working at different activities. So, someone who's at, a 1.5 met They're up, they're sitting, they're moving, whatever, very little. If we go to light exercise, that three metabolic equivalents, that's walking maybe 2 miles per hour on a treadmill, light cooking or chores. They tend to be a little more sedentary. Metabolic equivalents for someone who's brisk walking, we're going up to 4 miles an hour. They're participating in heavier, more demanding activities. And then greater than 6 METs would be our rigorous. Bear in mind when we look at how much exercise someone should be participating in, if someone does 30 minutes of exercise at a moderate activity level, that would be equivalent to maybe only 15 minutes of exercise at a vigorous. You're going to get similar benefits out of that. So when we're developing our programs, maybe we want to consider for our patients, well, how much time do they have to dedicate to exercise, and then work them at an appropriate level for them. The physical activity recommendations that are out there for the Department of Health and Human Services, we already know this, looking at 150, 300 minutes of moderate exercise a week for adults, or again, flip that, do 75 to 150 of vigorous. That is in addition to muscle strengthening. Remember, exercise is not just going to the gym. It could be walking, it could be dancing, it could be anything that interests that individual. For kids, getting them up and moving, maybe it's playing with the dog. There's lots of ways. The key is increasing that heart rate. One tool that we can use to get more insight on patients' physical activity is the Global Physical Activity Questionnaire. This is a self report that's going to ask the person related to how hard they're breathing to do different activities, if they consider their work, how they're getting from place to place, if they're walking or driving, what they do for recreation, how often do they sit, and how long they participate in different intensity activities. Curious study results. They completed this on New Yorkers, and they had the individuals complete the survey questionnaire. And of the study participants, 25% said they have greater than 960 minutes of activity that was at least moderate intensity a week. They followed up with accelerometry measurement, and not that our patients lie, but we may not always best know, including myself, how to interpret our activity. Accelerometry showed that less than 1% of the people actually achieved over 900 minutes a day. So that shows us we might need to spend a little time in helping our patients understand intensity of exercise. We all know that 10,000 steps a day. Well, where did that come from? The research that this is based on was a study that looked at almost 5,000 adults in the United States, and they looked at the risk of heart disease for individuals based on how many steps a day they did. So individuals who did less than 4,000 steps a day, they were at a higher risk of heart disease. And then when they categorized everyone, the more steps someone took a day, the less risk of heart disease. So people who took 8,000 steps a day, they were at a 50% lower risk. Individuals who did 12,000 were at a 65% lower risk. So that 10,000 is kind of what was settled on. This was just an observational cohort. They followed them over a 10-year time period and then looked back at their heart disease and their activity. So that doesn't mean 10,000, hey, you're good. It just means it decreases the risk. Those steps and activity that our patients are doing, it also has to be at a sufficient activity level. Just, slowly strolling through the mall window shopping, you're getting your steps in, but is it really getting a benefit? So, the American College of Sports Medicine has run studies to see, well, what is the pacing that is intensity that's really beneficial to correlate to, that moderate to vigorous metabolic equivalent level. And what they found is 100 steps a minute is moderate. Well, that's a little hard for us to time out if we want to actually teach it to our patients. So that would mean 1,000 steps in 10 minutes. And again, that might be a little difficult. So basically, 30 minutes seems to be a good amount of time, and you can pace that with accelerometers and easy for patients to remember. 3,000 steps, 30 minutes. If you're going faster than that, you're moving into vigorous level. If you're going less than that, it's too slow. Sample endurance exercise program from the American Association of Cardiovascular and Pulmonary Rehab. For general cardiovascular health, we're going to incorporate a warm up for our patients, some kind of light activity, stretching. When we look at the activity the individual will perform, you can use heart rate max, metabolic equivalents, the rate of perceived exertion, somewhere between 11 and 14. Monitor the response to exercise. We want to get up to 20 to 30 minutes, but you're not going to start your patient there. They may start at 10 minutes of gentle walking or 10 minutes of whatever exercise, and then you're only going to increase 1 to 5 minutes each time, each session that you see them, and monitor their response. And there are many different types of activity you can utilize. Find something that interests them. I put this tool in here. It takes a little bit of time to digest, but I wanted you to have this resource. Patients may be concerned about their safety with exercising, and we need to be concerned about that, which you all know. So there are many different ways we've talked about today about how to monitor patients, different diagnoses, different symptoms that they present with. So this helps you determine, based on many different factors, how safe it is for someone to exercise, and then it'll also let you know how closely you need to monitor them, and it lets you know, like, currently how they're functioning, to give you that guide of how risky exercise is for them. So that's something you can take your time to digest, and I have the reference here that explains it a little more. In terms of monitoring exercise intensity, we tend to use the talk test, heart rate, and rate of perceived exertion. Particular patients in phase 3 to 4 cardiac rehab, we're definitely teaching them how to monitor this themselves. The talk test is one that is commonly utilized to gauge exercise intensity based on the individual's ability to carry a conversation. Physiology behind it is looking at ventilatory thresholds. It began with the idea that, are you hearing your own breath? Let you know how hard you're exercising. What happens is, when you reach that ventilatory threshold as the muscles are exercising, when we first get to the fats contributing to burning the calories, which is, basically where we're working at a lower level for weight loss, lactate is increasing, carbon dioxide levels are going to rise. And then as we continue to exercise at a higher intensity, we're going to start to become out of breath, because that carbon dioxide is becoming more trapped as the lactic acid is building up. in the tissues. And then we reach our VO2 max where speech actually becomes suppressed, because if someone's talking, they're not taking in the oxygen and releasing that carbon dioxide. So at some point, the need for oxygen exceeds the need to be speaking. So speech is suppressed so that oxygen can be brought in. The way we actually utilize this in order to monitor patients and for them to utilize as a way of monitoring themselves is, can they, still talk when they're exercising? And if we just say, can you still talk? You can talk a lot of different ways, right? Are you talking one word? Are you carrying a full-blown conversation without any problems? So the way that a lot of the research suggests to do it is, you should use something that, if you're monitoring the patients, you would know what the cadence of speech should be. And for the patient, something that they would know. So we all know reciting the Pledge of Allegiance, right? It has a cadence to it. I pledge allegiance, little pause, to the flag, tiny pause, right? Or singing the Star Spangled Banner. I will save you, my singing. But we know what that kind of should sound like, and so do most individuals. So if you use something like that, you're going to know if they're able to speak comfortably. Are they unable to sing? So maybe they could say the words to the Star Spangled Banner, but kind of, but they can't actually sing it. If you ask them to sing, and then vigorous is where, you know, they're only getting a little out. So consider looking at using something that the cadence can be recognized of for speaking versus singing, to look to see if someone's at that moderate intensity where they can't sing but they can talk. Looking at heart rate, there are many different ways that we already know of to calculate that. The percentages to look at for a moderate intensity of activity level, we're looking at 65 to 75% of that max heart rate. For a vigorous intensity, we're looking at 76 to 96% of whichever value you use for the max heart rate. And then rate of perceived exertion, this particular scale, we know the Borg scale. We're looking at it based on the symptoms that the individual experiences or the perceptions they have of how hard they're working. How hard, do they feel their heart beating? How hard are they breathing and sweating? How tired do their muscles feel? Most sources say that when we're initially starting an exercise program, we're going to look at being somewhere between 11 and a 14, lower end to start. Maybe for some patients, we just start with 5 minutes of activity or 10. And then, just like we increase the number of reps and sets before we increase the weight, usually, of exercise, you're going to probably increase the time of the exercise before you increase the rate of perceived exertion. HIT training, I've mentioned a couple of times that the benefits for respiratory, cardiovascular, as well as the skeletal systems, research is emerging that it really provides similar benefits to other types of exercise to decrease the risk of cardiovascular disease. This is where the individual is going to alternate between periods of working at greater than 90%. Oops, sorry, 90% of their heart rate max, with periods of time where they're working, during recovery at maybe only 40%. And this helps improve insulin sensitivity, blood pressure, body composition, and really it'll help with that metabolic syndrome that contributes to a lot of these disease processes. Despite all of these different interventions for patients, some patients just need other mechanical devices to assist them. One that is utilized during surgery, if you read it in the op reports or you ever have the opportunity, it's really fascinating how it works. It's called an intra-aortic balloon pump. While they're working on the heart, they want to take some of the load off of it for the individual. So what they do is insert this balloon into the aorta and it's deflated. So the heart contracts, it pushes the blood through the aorta, then the balloon expands. So, with that balloon expanded in the aorta, it's keeping the blood out here going towards the periphery for perfusion, and it's not letting the blood back into that left ventricle that is already being strained. So, it takes some of the stress off that ventricle. And by taking the stress off the ventricle, which is a muscle, itself doesn't have as much of an oxygen and demand in that myocardial tissue. So it overall helps improve cardiac output. Devices that are going to also be utilized for certain patients, the extracorporeal membrane oxygen, the ECMO. This is utilized not only for patients with heart failure, it could be babies that have the meconium aspiration, individuals with hypothermia where the blood needs to be warmed, sepsis. It was utilized during COVID to support patients. And the simplest way to kind of explain it to patients, I think, is just most people understand what dialysis is to help the kidneys. This helps the heart. It'll take the blood out of the heart. It'll take it through an external perfusion device to do what the lungs would normally accomplish. And then it's going to put it back into the heart to go back out into the circulation. A device that we might actually see patients wearing is a ventricular assist device. This is going to take that blood out of the left ventricle, whirl it through a pump, and then push it back out through the aorta. This can be utilized as a bridge to recovery just to take the stress off that left ventricle. Someone may be waiting for transplant, and they're working on smaller, more portable versions that patients can actually use as their destination therapy if they're ineligible or can't receive that transplant that they need. We've taken time today to look at the pathogenesis of many different cardiovascular conditions and examine the research as to what we can do in rehab to enhance our exercise prescription and develop programs to promote quality of life and safe exercise and safe heart healthy behaviors for our individuals who are presenting with different cardiovascular pathologies as their primary or comorbidity diagnosis. Is it correct that you should not place a blood pressure cuff over clothing? Yes. And the research supports that for all types of blood pressure readings in the clinic, self monitoring, ambulatory monitoring, that depending on the research studies that you read, placing the cuff over clothing can increase the reading by 10 to 40 millimeters of mercury, depending on that thickness. The American Heart Association takes it even further and says it can make a difference of up to 50 millimeters of mercury. The concern here is that if the blood pressure is not taken on the bare arm and you have these other variables, even each time it's assessed of the thickness of the clothing, there can be inaccurate measurement that is occurring, and it could push that patient into values where medication would be indicated, but they may not really have high blood pressure. So it's important for us to educate our patients too that when they're doing home and self-monitoring, that they're not placing that blood pressure cuff over their clothes. Do e-cigarettes cause the same effects as tobacco smoking? There are many different effects of tobacco smoking. Honing in on what is most related to what we're discussing today, cardiovascular disease, electronic cigarettes, any type of heated tobacco products, vaping, nic. We'll talk about it just in the context of the nicotine specifically. The research is exploring what the actual mechanism is between smoking and vaping that particularly leads to cardiac arrhythmias. That is something that was coming up as I was looking at different studies. It seems that nicotine promotes atherogenic substrates, and this is going to be because of three specific mechanisms. They're finding that the electrical conduction within the heart, those different ion channels that promote the development of arrhythmias, are actually affected by the nicotine. Their action potentials are changed. Also, the nicotine seems to impact the structural remodeling within the heart, and it seems to be progressive of those myocytes, the actual cardiac cells, the myocardial interstitium, that it leads to hypertrophy of the cells, fibrosis, and the cardiac chambers become enlarged. The third mechanism that they're recognizing is that there seems to be an imbalance of autonomic control that occurs with that exposure to nicotine that alters the electrical conduction and then leads to these arrhythmias. One research study that I read looked at exposing rats to the e cigarettes, and they induced exposure 5 days a week for 2 months. They only did one session of exposure to the puffs a day. It was over 5 minutes, 10 puffs, and that was to approximate the consumption of a single cigarette or a single vape session. Unfortunately, the reality is individuals who are using those products are exposing themselves to even more than that. They did all kinds of different monitoring, and what they found is that the systolic blood pressure increased that chronic exposure to the products elevated the baseline systolic blood pressure in 2 weeks to greater than 130 millimeters of mercury. And then it went up to 140 millimeters of mercury after 4 weeks. And going all the way through the eighth week of this research study, they saw steady increases in that systolic blood pressure. Looking at electrocardiograms, telemetry, looking at arrhythmias, they found that the left ventricular end diastolic volume increased. That means as much blood wasn't being pushed out of that heart, that the ejection fraction was reduced. The left atrium became enlarged, more episodes of atrial fibrillation, fibrosis, just a lot of negative effects compared to the room air or the non nicotine exposed air. So they're really finding that there are a lot of negative effects, and many of the different organizations, they do not advocate e-cigarettes as an alternative when someone is trying to go through a smoking cessation program because there are still a lot of the same negative consequences. Can hydration level affect blood pressure? The short answer is yes, and whether it makes it go up or down is actually a little bit surprising, and we may not always see the same response in different patients or even in the same individual based on their circumstances. When we're drinking enough and we have good hydration, there is that fluid retention. Too much fluid retention is going to increase the blood volume. Patients may then hesitate to drink too much. However, there have been some recent studies related to this, and they looked at in individuals who were normotensive and individuals who already had high blood pressure. As they changed their hydration volume, what was the actual effect on their blood pressure? The particular study I'm referencing is out of Saudi Arabia. What they found is individuals who were considered to be dehydrated, we know that means that there's less extracellular water, lower blood pressure, lower blood volume for those individuals. If it drops too low, then we're going to see that individual become dizzy, maybe have an episode of syncope, nauseous. They're going to have, because of decreased perfusion to the brain, they might have blurred vision, start seeing fatigue, weakness, confusion. So the study recognized all of this. They also found that the body is going to compensate. And the typical compensation mechanism for this state of dehydration is for angiotensin to be released to compensate for the vasoconstriction, and blood pressure will then increase. Unfortunately, what happens sometimes is the body overcompensates, and you might actually see a rise in blood pressure in those individuals. What was really interesting is the research that looks at how chronic dehydration affects blood pressure. And this is where it's almost counterintuitive to the whole process we just talked about, that makes sense. Some of the explanations are that chronic dehydration actually leads to elevated blood pressure. So, hydration level is something to look at in our patients. Are they maybe not drinking enough? That's increasing their blood pressure. Are they not drinking enough because they don't want to have to walk to the bathroom extra? They don't want to ask for assistance. Maybe they don't have the standing or sitting tolerance to urinate. Do they have access? Can they physically swallow enough? Can they get the water? We need to think about this for our patients with high blood pressure. They do need to stay sufficiently hydrated. When our body's in that state of chronic dehydration, the research is suggesting that sodium levels, we know, are going to rise because there's a disproportionate relationship between the water and the sodium. And in response, vasopressin is released to help that body retain some of its water to try and normalize that relationship. It also results in vasoconstriction. And if someone already has high blood pressure and now they're vasoconstricting further, that can further contribute to the increased blood pressure. Another extended effect of this chronic dehydration is that excess sodium in the blood vessels is an inflammatory trigger. And they're starting to recognize that leukocytes are building up in that inner layer of the blood vessel that contributes to that vascular adhesion, and it makes the vessel more rigid, and then it's less effective in vasodilating and vasoconstricting. And we know that one of the main causes of hypertension is that inability of the vasculature to respond when it becomes too rigid. So this becomes a cycle, and that's why patients do need to continue to be monitored for their hydration level. Is it still standard to take pressure on the left arm? Good question. I didn't think to include this in the presentation. And we hear all different things about this. The American Heart Association actually published an article in 2022, um, just kind of reminding everyone and putting out their research from a newer study that no, that's not standard to take blood pressure in the left arm. What's actually recommended is to assess blood pressure in both the left and the right arm, and then see which value is higher and utilize that arm to assess the blood pressure. The reason is if there is a difference in the extremities for whatever reason, if assessment is always completed on the extremity with the lower pressure, that person may not be recognized as having hypertension, or may not even be reading their actual response to the intervention because it's the other arm that tends to be higher. There was a study where researchers analyzed the medical data for over 53,000 people, from 23 different studies, multiple different countries all over the world. And they found that in these participants, who they were average age, middle age, like 60 years old, they found that by using the arm that had the lower reading, whether it was let's say it happened to be the left, because everyone usually goes there. Using that arm by the lower reading, 12% of people who actually had hypertension were not recognized. And that's a pretty significant statistic. So, what's recommended is to check both arms and then actually utilize the arm that consistently has that higher blood pressure. When our patients are performing this at home, the recommendation for that ambulatory device or home monitoring type of device is that, again, they need to check both arms to see their pattern, to see which one is consistently higher outside the clinic, and then use that extremity for their actual blood pressure reading.